this video, we will discuss Rhino-Orbital Mucormycosis. Rhino-Orbital Mucormycosis is a rare but highly aggressive fungal infection caused by the fungi of the Mucorrhizaceae family. It typically affects immunocompromised patients, especially those with uncontrolled diabetes and diabetic ketoacidosis, and is associated with high mortality. It is rare in immunocompetent individuals. Mode of infection and spread. The infection is acquired by inhalation of spores, leading to an initial upper respiratory tract infection. It spreads to the paranasal sinuses and then to the orbit. It can then spread to the brain, and the fungal hyphae invade the blood vessels, causing occlusive vasculitis and tissue infarction. Pathology. The hallmark of mucormycosis is invasion of blood vessels by fungal hyphae, resulting in occlusive vasculitis, ischemia, and tissue necrosis. This leads to the classic black eschar seen on the palate, nasal structures, eyelid, and skin. Symptoms. The patients often present with gradually progressive facial and periorbital swelling, diplopia, and visual loss. Signs. Clinically, signs may resemble bacterial orbital cellulitis, but tend to be less acute with slower progression. The presence of black necrotic eschar is a key diagnostic clue and should immediately raise suspicion of mucormycosis. Eschar may involve the palate, nasal cavity, eyelids, or skin. Complications. Mucormycosis is associated with severe complications including retinal vascular occlusion, multiple cranial nerve palsies, cerebrovascular occlusion, and intracranial spread, contributing to its high fatality rate. Investigations. Investigations are similar to those used in bacterial orbital cellulitis. Imaging is essential to assess the extent of orbital and intracranial involvement, while microbiological and histopathological confirmation establishes the diagnosis. Treatment. Rhino-orbital mucormycosis is a medical emergency. Early diagnosis and rapid correction of underlying metabolic abnormalities, especially diabetic ketoacidosis, are essential for survival. A multidisciplinary management is required. Antifungal therapy. Treatment requires prompt initiation of intravenous antifungal therapy. In addition, daily packing and irrigation of affected areas with antifungal agents may be required. Surgical management. Surgical management is aggressive and involves wide excision of devitalized and necrotic tissues. In advanced or unresponsive cases, orbital excenteration may be necessary to control disease and reduce the risk of death. Adjunctive therapy. Adjunctive hyperbaric oxygen therapy may be beneficial by improving tissue oxygenation, but it should only be used alongside antifungal therapy and surgical debridement. To summarize, Rhino-orbital mucormycosis occurs mainly in diabetics with ketoacidosis. Angioinvasion causes tissue necrosis. The black eschar is a key diagnostic sign. Progression is slower than bacterial cellulitis. Treatment involves antifungals and debridement of the necrotic tissue. high mortality if treatment is delayed.